So now after seeing the normal angles, I'll be talking something about the diagrammatic rendering, video capturing, special situations and challenging situations. So doing a gonioscopy in your routine glaucoma workup is really important, but equally important is documenting it, because next time when you see the patient, you won't be remembering what exactly you have seen. So that is the importance of diagrammatic rendering, and also it is also useful for patient education as well as for training your postgraduates or your fellows, because we know how much difficulty we had when our postgraduate period doing a gonioscopy. It was really difficult. So now I do not have any financial interest. Now coming to the diagrammatic rendering, when you talk about diagrammatic rendering, you have to know about the Becker's goniogram, which Becker described in 1972. Here you see the dark line, that is a scleral spur. 3 outer lines are the Schwalbe's line and the trabecular meshwork. 3 inner lines are the various level of iris insertion into the ciliary body. So if you have a case sheet, you can attach such a Becker goniogram, and whatever you see, you can mark it. It's all color coded. So you can mark the angle recession, blood, pigments, any PAS, so you have to mark it. Now, when you talk about the documentation, of course, you have to know the grading system. Schaffer system, already Dr. Manoj sir has covered it. I'll talk a little bit about the Spathe system. I'm not going into detail. So Spathe gives a very detailed recording of level of iris insertion, angular width, iris contour, TM pigmentation, and effect of indentation. So talking about the level of iris insertion, wherever the iris is inserted into the angle, that is the level which they have described. So you have A anterior to Schwalbe's line, B behind the Schwalbe's line, C scleral spur, D is deep and extremely deep. So this gives us an idea how the iris insertion is. Second, the angular width, it just described, it is similar to the Schaffer's grading. You have to just tell the degree of angle. Now iris contour is also important. Normally the normal contour is represented as F, that is flat. C is a concave one which you can get in an angle closure. B is a bowed one which you can get in a pigment dispersion syndrome. And P is a plateau iris, which already sir has showed you. And according to the trabecular meshwork pigmentation, you have various grading from 0, trace, 1, 2, 3, and 4. So one small example, the first one, it is marked as A in brackets C15B3 plus. What it means is that when you're seeing the angle, it is A, that is iris is inserted anterior to the Schwalbe's line. But once you do the indentation gonioscopy, you can see the scleral spur. So that is the meaning of that. And then 15 is a 15-degree angle. B is a bowed iris contour, and 3 plus is trabecular meshwork pigmentation. Similarly, the below one you have D45F2 plus, which means that it is the iris is inserted deep into the ciliary body. 45-degree angle, F is a flat iris contour, and you have the 2 plus pigmentation. So making it simple, you can just use 2 cross lines and record whatever posterior most structure that you see. That is one of the things which we usually do, and then mark the clock cover of the peripheral anterior synechiae where you have seen, and any other abnormalities like pigmentation, iris process, any other abnormalities. So, but now we have all gone paperless. Now everything is shifting to the EMR. So having this goniogram is little difficult. So the next era is of video capturing and photos, which we have already seen many photos. So for video capturing, this is to document your findings, convenient for patient education and easy integration into network. So the question comes, which mirror you can use for the video capturing. So you have the Goldman 3 and 1 mirror, which is a non-indentation type, Zeiss and Posner mirror, which are the indentation types. But when you're taking a photo or video, it's always better to have the non-indentation one, which you use the coupling gel. It will have more stability, so the videos will have good clarity. And if you have trabeculectomy, trabeculoplasty lens, like SLT and MLT lens if you have, these gives little more clarity. So the images which I'm going to show are all taken in the BQ 900 slit lamp, Hagstreet slit lamp in imaging module IM 900. These were taken when I was doing fellowship with Dr. Satyan sir at Coimbatore. So this gives very good imaging, and always pay attention to the image on the screen rather than looking through your eyepiece. Now, but it's not always practical to have the slit lamp and imaging modules, which are all really expensive. So one of the example is this telescopic mobile holder, which actually Dr. John Davis Akra, who is from Chaitanya Hospital and West End Hospital, he has taken lots of beautiful images using his mobile camera and this telescopic mobile holder, which is available in the Amazon with less than 500 rupees. It can be attached to the Hack Street model or the Zeiss model slit lamp, and you can take beautiful photos of gonioscope, angles. So, and he has also demonstrated how to use it. Another example, if you have attended the smartphone imaging previous session, smartphone gonioscopy, which was put forward by the Dr. Prithvi Chandrakant and team. Here they are taking the images without the help of slit lamp. Along the mobile camera, behind the mobile camera, they are using 10 diopters of intraocular lens, and then keeping the gonioscope on patient either supine or sitting position, and you can take the image even without the slit lamp. Then you have direct imaging of gonio mirror by smartphone by Dr. Nilesh Kumar. So nowadays everything is coming up, all these smartphone technologies. Now I'll be showing some examples of some of the clinical interpretations. Some of the videos may be repeated, but still the more you see, the more you know. So you have pigments, this kind of pigments in angle is generally seen in pseudo-exfoliation syndrome. The patchy pigments which you get is seen in the pseudo-exfoliation. And if you have dark pigments which is uniform throughout the angle, these are seen in pigment dispersion syndrome. So if you have a pigment dispersion syndrome with a bored iris, you can actually do a peripheral iridotomy, and it can, in some cases, it helps in reducing the pigment dispersion. Now this is another example of an angle recession. There is an evidence of trauma, and you can see that the ciliary body band, it's wide and the iris is actually recessed from that. So that is an angle recession. Any patient coming to you with a shuttlecock injury or any blunt trauma to the eye, after the initial phase of inflammation settles, any bleeding, it has to settle, and then do a gonioscopy, you have to rule out an angle recession. Angle recession is really common in the shuttlecock injuries. So, and also it is equally important to compare both eyes. You see both eyes, there will be a difference. The other eye will be completely normal and this will have a wide angle. So this is an example of traumatic angle recession. Traumatic angle recession glaucoma, it can come any number of years after the trauma. Sometimes the patient may not be even remembering that they had an injury. It might be 5 years back, but they can have a raised IOP after 5 years. So it can come anytime. And this is one of the example of the double hump pattern. On indentation, you get this hump pattern, which is seen in the plateau iris. So another example of, this is an example of peripheral anterior synechia here, which is more anteriorly into the cornea. And you can see fine processes here in both the angles. These are iris processes. Iris processes are normal findings which we see in angle. You should not mistaken it for the peripheral anterior synechia. PAS will be little more broader, and this will be very thin and lacy, and it won't block the angle structures. And here you can see the blood in Schlem's canal. And this was a video of a patient who came to us with for cataract evaluation. And on examination, the cornea had stellate capice in her endothelium. And on doing gonioscopy, you can see that the angle had fine vessels, which on doing gonioscopy actually started bleeding. So this is a case of Fuchs uveitis. The patient's IOP was normal. You can see the active blood that is coming here. So in Fuchs, you will have very thin vessels in the angles, which will bleed on gonioscopy, or it can also bleed on table when you're doing the cataract surgery. Once the IOP comes down, you will have bleed from the angle. So another example of this gonioscopy of seeing the trabeculectomy ostium. So you have a bleb and you see that IOP is raised. You have to definitely see how the ostium is. So here we have a patient who has an iris blocking the trabeculectomy ostium. So glaucoma examination is never complete without a gonioscopy. Gonioscopy is a must not only for glaucoma, even other conditions also. Here you have the fine new vessels that are seen in the angle. So these new vessels will cross the scleral spur. So this is an example of ciliary processes that you see in the angle, while doing the gonioscopy. This can be seen because this is an NVG patient and the pupil is mid-dilated. Now coming to, this patient had PDR and he came with a raised IOP. On examination, slit lamp didn't show any NVI, but on seeing the gonioscopy there was bleed in the angle. So it's not always that you will get an NVI in the pupillary margin. You always have to see the angle to rule out NVG. And another patient, this patient actually went to 2 or 3 doctors complaining of irritation and watering, and he had this corneal decompensation which was there inferiorly. But no, everyone gave drops, but only when we did a gonioscopy, we could see a foreign body that is sitting in the angle. This was a cause of his corneal decompensation in that particular area. So we did we removed this foreign body, and he was little bit better, not completely all right, because it was a long term. He do not give any history of any injury. So, and some of the challenging situations, I think I'll take 2 more minutes. So always you have a doubt when you see a pigmented Schwalbe's line, whether this is a Schwalbe's line or a trabecular meshwork. So what do you do in such cases? You have to do the corneal wedge technique. Corneal wedge technique is nothing but you have to keep a small slit and keep it at an angle of 60 degree. You can see 2 lines which is coming from the anterior and the posterior surface of the cornea. This meet together at the Schwalbe's line. So this is an example of corneal wedge technique. You can see the anterior one and the posterior one joined together at that line. That is the corneal wedge which is corresponding to the Schwalbe's line. So never confuse a pigmented Schwalbe's line with a trabecular meshwork, and always examine the inferior angle first, which will be seen very clearly, and only then go to the next angles. Then if you put excessive pressure on the gonioscope, you can have corneal folds. So it's always important to keep the optimum pressure. And manipulative gonioscopy, already Dr. Ramnan has shown you. And in case of edematous cornea, you can use anhydrous glycerol drops to see the angles. Now, special thanks to my mentor, Dr. P. Satyan sir, and acknowledgement is Dr. P. Satyan sir and Dr. Prasanna Venkatesh Ramesh. Thank you.